I'd like to thank AbbVie for inviting me to speak, and I'd like to thank you all for being here so late in the afternoon. It's been a very informative day with lots of really nice lectures covering most areas of IBD. I'm hopeful that I'd be able to tie things together with this talk. Now, this is a couple of disclaimers and disclosures for myself, Dr. Uthman, and Professor Irving. Now, the objectives of this talk is to focus on the following. Number one, understand the importance of mucosal healing as our ultimate treatment goal in IBD to achieve optimized patient outcomes. Second, to understand the impact of suboptimal disease control and how earlier introduction of therapies and timely clinical action using a tight monitoring approach can support achieving mucosal healing in practice. And finally, reflect on how clinical decisions are made in practice and consider strategies for optimizing decision-making. So we'll start with a little bit of talk about mucosal healing. So these are the contents. I'm just going to skip through this. So number one, we'll focus on how endpoints have evolved over the past decade. First of all, let's try to differentiate between a few terminologies. So number one, endpoint. So endpoint is a clinical definition of success at predefined time points. So this is a point that basically may have an impact on disease course, and it's used mainly for comparison in clinical trials and for regulatory approval. So this is the language used when you read an article reporting on, for example, the efficacy of a certain drug. Target, on the other hand, is a short-term ambition that must be achievable and will impact outcome if met. It's modifiable with therapeutic optimization. Hence, the treat-to-target strategy. So this is kind of common language between physicians and what we consider something that has to be achieved in order to be able to help our patients. Finally, a goal. So goal is a long-term ambition of treatment defined by an individual patient and by the physician. So this is common language between us and the patients. How have endpoints changed over time? This is a really nice illustration showing clinical trials in Crohn's disease for advanced therapies since 1997 all the way to 2022. You can see from the start point with studies like the Targon study and ACCENT-1 for infliximab and Crohn's, how we used to rely on subjective endpoints, namely symptomatic response based on CDAI as was used in the Targon study. Moving forward, as you can see with drugs that were subsequently evaluated, such as natalizumab, adalimumab, certolizumab, all anti-TNF agents, you see a gradual trend towards more objective endpoints. And finally, you can see the real change happening somewhere between 2014 and 18, where all of a sudden you're seeing endoscopic endpoints coming in as something that you want to rely on when you're evaluating a drug, because this is more objective. So finally, you can see in 2022, the studies for risankizumab and upadacitinib relying on both co-primary endpoints of clinical and endoscopic endpoints together for Crohn's disease. And this is the first time this is used for induction and maintenance studies for Crohn's disease. Now, let's take a look at ulcerative colitis. Although these are different endpoints, but it means the same thing. You can see in 2005, when the first drug or the first advanced therapy for ulcerative colitis was evaluated, infliximab in Act 1 and Act 2, we used the Mayo endoscopic score 0-1. And then moving forward, as you can see through time, we started to rely on more tighter forms of remission. So we moved forward to use, rather than a Mayo of 1, we now look at a Mayo of 0. Then we started looking deeply into histology until finally in 2023, we're focusing on mucosal healing defined by both endoscopy and histology, reflecting how we thrive for deeper forms of remission. And this is exactly what we are describing in this illustration. You can see starting at the beginning with symptomatic improvement to clinical remission, steroid-free remission, a really important endpoint, May endoscopic subscore of 0-1, May endoscopic subscore of 0, and then finally mucosal healing. Now, why? Why did this change over time? Why did these endpoints go towards more objective forms? And why did we focus on endoscopy and specifically mucosal healing? There has to be a reason behind this, literally something in the literature that tells us that this is the right thing to do. So you can see the literature is very supportive of mucosal healing. This is a very nice meta-analysis that included 673 patients from 12 different studies, and they compared between those who achieved and did not achieve mucosal healing at the time of the first assessment. So those who had mucosal healing demonstrated sustained clinical remission, so beyond 50 weeks in 69% of patients versus only 43% in those who did not demonstrate mucosal healing. A very huge difference between these two patient subsets. Now on the right side, there's more outcomes that came along with this endpoint. So you can see lower risk of disease progression, lower rates of steroid-free remission, a decrease in future need of steroids, low risk of relapse over 5 years, decreased risk of hospitalization, treatment failure, and surgery, all in favor of mucosal healing. These are the individual studies included in this meta-analysis, and as you can see on the right side, the forest plot showing us a higher odds ratio, closer to 4, 4.5 in favor of mucosal healing, favoring mucosal healing and associated with a higher odds of long-term clinical remission. There's more studies out there that support mucosal healing. For example, this is a retrospective analysis of data from the CALM study. And here you have patients with moderate to severe Crohn's disease, so 122 patients. On the left side, you can see how there's a differentiation between those with endoscopic remission and those without, starting early on in the course following the introduction of therapy, with 59% reduction in disease progression with time in those who had mucosal healing or endoscopic remission, compared to those that did not. On the right side, if you look at a more stringent endpoint, which is deep remission, combining CDAI-defined remission along with endoscopic remission defined by the CDAIS and absence of deep ulceration and no steroid use for at least 8 weeks. Now you have 81% reduction in the risk of major adverse outcomes. So this is all in favor of going with deeper forms of remission. Now, there's a lot of other benefits. So when a patient reaches mucosal healing, they're more likely to be and remain off steroids. You can see this again in this analysis on the left side. So we have steroid-free remission 3 to 4 years based on assessment of SES-CD at 2 years. And you can see the huge difference between those who did demonstrate this outcome, whether or not they were treated with anti-TNF or not. Now, obviously, when you treat patients with these advanced therapies, what you would hope to be able to promise your patient is that as long as you receive this treatment, not only are you more likely to be in sustained clinical remission of steroids, but more importantly, you're less likely to need to be hospitalized in the future. And you can see that in this analysis. This is a retrospective study of patients with Crohn's disease who achieved mucosal healing, followed treated with multiple biologics or multiple forms of biologics. On the left side, you can see in this figure how there is a clear separation in the Kaplan-Meier curve early on in the course of follow-up between those who demonstrated mucosal healing and those who did not. On the right side, you can see the risk of treatment failure also being very different between these two patient bases. Now, obviously, when patients have complicated disease, when they fail treatment and they go for long periods of time with disease activity, they become at risk for complications, which ultimately translate into the need for surgery. So if you eventually need to go for surgery, that reflects a longer period of uncontrolled disease or failure of therapy. And what you can see with the literature is patients who achieve mucosal healing are clearly less likely to require surgery with time. This is systematic review and meta-analysis that demonstrated association of mucosal healing at the first endoscopic assessment with the Crohn's disease related surgery-free rate. You can see on the right side in the forest plot, mucosal healing is clearly associated with a higher odds of not needing surgery with time. Again, you can see that in these studies, on the left side, a study which is from the Ipsen database. This is a population-based cohort study involving 227 patients. And on the right side, another retrospective study involving 84 patients, comparing those who had demonstrated mucosal healing and those who did not, and showing the same results. What about ulcerative colitis? And we all treat ulcerative colitis differently in a way. So this is a meta-analysis that involved over 2,000 patients from 13 studies comparing mucosal healing versus no mucosal healing, and again looking at sustained outcomes. So long-term clinical remission for at least 52 weeks and at least 6 months after mucosal healing assessment were achieved in 65% of patients with mucosal healing versus 34% in those with no mucosal healing, so almost the double. So it's almost like you're telling the patient you have half or 50% reduction in the need or in the chance of developing relapse during the time of follow-up. Furthermore, there's higher increase in steroid-free remission, lower rates of hospitalization, decreased need for surgery, and ultimately better quality of life. Here are the individual studies that were pulled together to give us this odds ratio, again, of about 4.5. There is lots of debate that we've seen over time in many meetings about whether you'd want to go with a Mayo score of 0 versus a Mayo score of 1 endoscopically in patients with ulcerative colitis. And ultimately, it was very clear that a Mayo score of 0 brought a lot of benefit compared to a Mayo score of 1. So obviously, a deeper form of endoscopic response remission can lead to better outcomes. And you can see here in patients with MES of 0 on the left side versus those of 1 on the right side, there's a huge difference in terms of the risk of clinical relapse over time. And the right side, you can see how this is also different depending on the extent of the disease. Now, being off steroids, it's really important. I'm sure we've all had that patient where you're, evaluating in clinic, you're asking about symptoms, the patient has no symptoms, no blood, no diarrhea, so you're happy, the patient's happy, and all of a sudden the patient says, well, when do I get off steroids? So, this is sometimes something that we overlook, and I think it's really important to always make sure that you wean patients off of steroids in time, because being on steroids while on a biologic or requiring steroids while on a biologic is, in a way, considered failure of therapy. This is systematic review and analysis, again, the one I showed, highlighting the association between mucosal healing and steroid-free remission in patients with ulcerative colitis, and you can see almost an odds ratio of 10, which is fairly significant. I'm just going to skip through this one. So moving on to hospitalization, we talked about this in Crohn's disease, in ulcerative colitis. There's a clear benefit in terms of the risk of hospitalization being lower in patients who reach the endpoint of mucosal healing with therapy. Of course, colectomy, which is considered a very hard endpoint, and requires a long time to evaluate and prove. You can see here in this meta-analysis and comparing patients with mucosal healing and those without, there is, again, an odds ratio of about 4 favoring mucosal healing over no mucosal healing in terms of risk of colectomy. Now, finally, as we all agree, ultimately, the patient's quality of life and ability to function on a social level is really important. And you can see mucosal healing offers a better quality of life ultimately, over time, patients with mucosal healing tend to do better in terms of work productivity, less absenteeism, and overall social engagement. And this is something that has been reproduced with multiple biologics and multiple studies over the past decade. Now, that's what I think we can say about the relevance of mucosal healing and how it reflects on other outcomes. Now, there's some points we need to focus on when we talk about monitoring patients. We heard Dr. Sarah this morning talk to us in depth about how to monitor patients. We heard about STRIDE-2 guidelines and tools available to be able to monitor patients in clinic. So I'm not going to spend too much time, but I'd like to touch on a few important points. So there are two main misconceptions that, in a way, prevent the adoption of the treat-to-target strategy and mucosal healing as an endpoint. One is that symptoms are good enough. You don't need to really, focus on endoscopy. And number two, even when you convince people that symptoms are not good enough, the second argument is that we don't have therapies that can achieve mucosal healing, which is absolutely false, because we have lots of therapies that are able to induce mucosal healing. This is the STRIDE-2 algorithm that we've seen today multiple times. We've heard how this strategy is followed, the difference between short, intermediate, and long-term targets, and how this not achieving these targets triggers escalation and then subsequently reassessment, and so on and so forth. These are the immediate, intermediate, and long-term targets that are used. Now, why do we follow a treat-to-target strategy? Why do we aim for mucosal healing and deep remission? In Crohn's disease, we know that this is a time-sensitive disease and that prolonged periods of active disease and delay in introducing effective treatment can lead to bowel damage and ultimately complication that lead to the need for surgery. You can see on the left side the famous Lehmann Index paper figure that we've seen in many IBD meetings. But the reason this figure is really popular because it really reflects the reality of Crohn's disease. You can see the black line fluctuating, reflecting periods of disease activity and how it drives the progressive increase in the blue line, which reflects bowel damage with time and then ultimately the development of complications and stricture. And of course, we know that when patients are in the phase of an inflammatory type of phenotype before stricturing, fistulization occurs, that is the time when you'd want to introduce an effective therapy that prevents subsequent transformation into the more complicated phenotypes reflecting bowel damage. On the right side, you can see that window of opportunity. So ultimately, this is what we're looking for. We're looking for a flat curve and no complication, which ultimately decreases the risk of surgery. Now, a holistic monitoring approach is required when you have patients with IBD seen in your clinic. We do know what the ECHO guidelines say with regards to the need to wean off steroids. We've talked about this before. It's really important to be able to get patients off steroids and not use steroids frequently due to the side effects associated with this medication. Now, of course, we've heard about monitoring and the use of or utility of non-invasive biomarkers. We've heard about ultrasound today, and clearly it is obvious that patient preference is towards these non-invasive tools. I'm sure patients would rather do an ultrasound compared to giving you a stool sample or even undergoing colonoscopy. And you can see this demonstrated in this nice survey reflecting patient preference for different forms of evaluation for Crohn's disease and ulcerative colitis. We talked about quality of life and how paying attention to this part of patient's life is really important. It's really important to be able to look beyond symptoms, biomarkers, and endoscopy, and focus on patients' quality of life and contribution to society. And this is something that is proven to be very important to patients themselves. There's the IBD disc that can be used easily in clinic to be able to evaluate patients with IBD. So thank you very much for paying attention. I'm going to